SHOs at Royal London Hospital, and he's going to be talking about vertebrae anatomy, spinal cord, and spinal cord blood supply. So we do ask that you turn off your videos. I think I can hear some sound, so please make sure your microphones are muted so you don't interrupt. If you have any questions in between, I think Hassan said that he's very happy to take them, I believe. So just raise your hand and one of the moderators will address that. But yeah, other than that, yeah, off to you, Hassan.
Thanks. Yeah, today we'll discuss the vertebral anatomy and some of the aspects of blood supply. It's just osteology in terms of the vertebral column osteology, not much on soft tissue. So the vertebral column is a pillar, is a column that supports the weight of part of the body. So it supports the weight of the skull up here, and then the upper limbs are connected here and here, and the ribs are connected here, and then it transmits that weight down through the pelvis down to the lower limbs. So it's important for this system to function normally, because any abnormalities or failure in this system would produce one or more of these three things. So pain, if you have any fracture, or if you have any disc protrusion, any abnormality in the spinal cord, if you have metastasis or any disease of the spinal cord, it will cause pain. It may also cause deformity, and you see kyphotic deformity, especially, for example, in older people or people with scoliosis, can be congenital scoliosis. So one of the major problems are deformities, and it's very debilitating thing to have. The third thing is neurological deficits. So if, for example, you fracture your neck and you compress the spinal cord here, you will have quadriplegia, or the patient may become paralyzed in their arms or legs. If you have a fracture here and compression of the cord here, it doesn't have to be a fracture, by the way, it can be anything, anything compressing the spinal cord. This may lead to weakness in the lower limbs, or may lead to disturbance in bowel or bladder symptoms, bowel bladder functions. So you end up with sphincter symptoms. So these three abnormalities arise from failure in the vertebral column system. So as a whole, we have 33 vertebrae, as you know. So 7 of these are cervical vertebrae. We've got 12 thoracic vertebrae, 5 lumbar vertebrae, 5 sacral vertebrae, and 4 coccygeal vertebrae. And we'll come into details a little bit later. So the majority of this talk will be about the typical and atypical vertebrae. So the typical vertebra has a body and an arch. This arch is formed by pedicles and laminae, and attached to this is several processes. So you have 1 spinous process, 2 transverse processes, 1 on each side, and 4 articular processes, 2 superior and 2 inferior. And we also have an important structure which is called the intervertebral foramina, or foramen, and this is formed by notches in the pedicle, and we'll come into the details in here. So here we're talking about the typical vertebra.
I think we can't see you move your slide. I think we're still on the second slide. We're still on the second slide.
So I am on the 3rd slide. Can you see that?
No, we're stuck on vertebral column.
Okay, I'll just let me close this up and come back. Any better?
So we're on slide 1.
Okay.
Yep, it's now working, I think.
Sorry, just try and open it again. Any joy?
Yep, it's working. Sorry, guys.
Okay. What is top? What can you see now?
C4 vertebra.
Okay, so C4, perfect. So, we're talking about, we'll talk about the typical vertebra and the atypical vertebra. And as an example for the typical vertebra, we have C4 here. So this is cervical vertebra number 4. This is one of the typical vertebra, and we said they all have a body. So this is the body. Can you see the mouse cursor at all? Can you see the cursor moving?
Yeah, we can see the cursor.
Okay, perfect. So this is the body of the vertebra, and this is the arch. So the body lies anterior, and the arch lies posterior. Okay, so this is anterior, this is posterior. So the arch is composed of lamina. So this is a lamina, and this is a lamina, and pedicles. So this is a pedicle, and this is a pedicle. And other notable structure are processes, like we said. So we have a spinous process. The spinous process is formed by the junction of the two laminae, right? So a lamina and a lamina, they meet in the middle and they form a spinous process. The other processes that we have are the transverse process. One is here and the other is here. The notable thing in the typical vertebra, cervical vertebra, is that the spinous process is bifid. So it has a notch in the middle. It has a bifid spinous process. Another important thing in the cervical, and this really helps you with identifying a cervical vertebra, typical cervical vertebra, is that the transverse process here have a foramen, and this foramen is for the passage of a major vessel, and it is the vertebral artery. All right. Another important feature, so the thing that I would be looking for if I was in an exam and I was told to identify which vertebra this specimen is coming from, I would look for the spinous process, because you don't see this in other vertebrae, in non-cervical vertebrae, and also this bit, which is the transverse foramen. Other less obvious features are the canal. It's wide, the spinal canal, or the spinal, here it's a foramen, and they connect together and they become a canal eventually. So you see it's large compared to the rest of the vertebrae down in the spinal cord, in the vertebral column. Another feature is the body. It's more of a rectangular shape and it's small in size, right? So these are the main features in a cervical and a typical cervical vertebra. Next, we'll look at another typical vertebra, but this time it's from the thoracic region. So we're looking at T4. So here we'll have a body and an arch. As always, the arch is composed of different bits. So here we can see lamina, and here we can see a pedicle and a pedicle. And when two laminae meet in the middle, they form a spinous process. And on the sides, if you see a process there, that is a transverse process. Here you can see the body is a little bit larger compared to the cervical vertebra, and the canal is narrower compared to the cervical vertebra foramen. So the foramen here is a little bit narrower. So these are the main features of a thoracic vertebra. So at the lumbar level, we have the typical L3 vertebra, and you can see that this is a body lying anteriorly, and this is an arch lying posteriorly. So the arch is composed of lamina, and here the lamina looks a little bit smaller than it is, or shorter, let's say, compared to the cervical vertebra. And you have pedicles anteriorly. So lamina in the posteriorly and pedicles anteriorly. So you have two laminae meeting in the middle, so they form a process, and that's a spinous process. And you have two processes on each side heading laterally, so these are the transverse processes. The body here definitely looks larger than the body in the previous two slides, right? And this is true. This is the lumbar vertebra has the largest of the bodies in the vertebral column, and the canal looks a little bit larger compared to the canal or the foramen in the thoracic vertebra. So the reason that you have larger foramen in this region is because in the spinal cord you have two dilations. You have the cervical dilation and the or enlargement and the lumbar enlargement. So it's kind of where all of the nerves of your upper limbs and lower limbs come out. So that's where you have these enlargements. So the foramen here is, then it's normal for the foramen here to be a little bit larger compared to the thoracic foramen, and that's because they need to accommodate for the cervical, and in this case here, the lumbar enlargement. So this is again a typical vertebra. However, if you've noticed that we didn't speak about the third type of a process that we have in the vertebrae, which is the articular processes. So we talked about the spinous process and we talked about the transverse process. However, and that's because they're difficult to appreciate in an axial view. So I didn't say. So this is an axial view. So an axial view means that you're looking at the structure from either the top or the bottom. And in scans, in clinical scans, the convention is that you're looking at the structure from the bottom. So as if you're standing at the feet of the patient. So sorry, it's difficult. You can see that it's there. It's just difficult to appreciate. However, if you're looking at this oblique view, you can see that you have a few more spikes going up and here, up and down. So this is another process, and somewhere around here, obscured by the body, is another process. So these are called articular processes, and the articular processes are you have two superior, two inferior, and they are supposed to be articulating with the vertebra above. So the superior articular process from this vertebra will articulate with the inferior articular process of the vertebra above it. And the same goes for the inferior articular process, where it articulates with the superior articular process in the inferior vertebra. As you can see here, there is a notch. So in the pedicle doesn't go all the way down here because they have to, one, accommodate for this articular facet and the opposing articular facet. So there's a joint in here, and they have to accommodate for the nerves, the spinal nerves that will be exiting or entering the spinal cord at this point. So the pedicle will eventually make a space for the nerve. So this space is called notch, and this notch, when in an intact vertebral column, will form a canal, and this canal is called the intervertebral canal or foramen, which allows for the passage of the spinal nerves. So this is a sagittal view. So now we're looking at the spinal cord, at the spine from the side, and looking at it, you can appreciate the spinous process here, here, and here. So this is the cervical, this is the thoracic, and this is the lumbar. So the same features that we talked about is that the spinous processes are here, and this is the same for all of the segments of the spine, so they lie posteriorly. They're a bit different in their orientation. So the spinous process in the thoracic spine, they're kind of inclined and pointing downward. In the lumbar spine, they kind of straight and pointing posteriorly, and here they're kind of in the middle. So the point is, you can, from looking at the spine, you can guesstimate what level you're looking at. Also, you can appreciate the difference in size in the bodies of the different vertebrae. So you can see in a comparison between L1 here and T1 here, there's a massive difference in size. So this can also be appreciated on a scan. Also, you can see the articulation between the different articular processes. So, for example, this is the articular process of the inferior articular process of T1 articulating with the superior articular process of T2, and the inferior of T2 with the superior of T3, and so on and so forth. To a lesser extent, you can see here the articulation. You actually can't really see it here because the transverse process here is covering and obscuring the articulation. But you can see clearly see the joint actually being formed in these thoracic vertebrae. The same goes for the cervical vertebra. It's because the orientation of the joint allows you to see what's going on in the joint in this case, and here as well, but not really in here. Maybe the last thing to see in this image is the intervertebral foramen. So you have this foramen and this foramen and this foramen. This is where the spinal nerves come out of the spinal cord, and you can see them in here. They're quite small in the cervical region. They're almost longitudinal in shape, or T-shaped structures. So this slide's a bit busy, but most of this we've already covered. It's kind of summarizes what we've discussed already. So this column is for the cervical vertebrae, and the typical cervical vertebrae are from C3 to C6. The thoracic are from T2 to T9. The lumbar are from L1 to 5. So everything out of this range is atypical vertebra. So in terms of the body, we said the body is small compared to in the cervical region is small compared to the thoracic and lumbar, as also the shape is different. So it's transversely broad, or you can say it's rectangular. And here it's heart-shaped, and here it's kidney-shaped. In terms of the costal facet, so of course, because you don't have ribs in the cervical region normally, you don't have costal facets, and also you don't have ribs in the lumbar region, so you don't have costal facets. So it's basically surfaces for joining or articulating with the ribs. So of course you have the ribs in the thorax, so you have costal facets in the on the surface of the thoracic vertebra. In terms of the vertebral foramen, we also said that they're large, and they had to be large because they need to accommodate for the cervical enlargement. They're smaller and circular in the thoracic region, and they're again larger to accommodate for the lumbar enlargement in the lumbar region. The spinous processes in the cervical region, they are short, they are bifid, and they are inclined inferiorly. And we said this is something that you can appreciate in a sagittal view, as in this one. And in here, they are long and inclined inferiorly. And they overlap in these, so maybe not exactly these, but more inferiorly in the thoracic region, they kind of overlapping. In the lumbar region, the spinous processes are short and flat and quadrangular in shape. They're projecting posteriorly. So they're pointing posteriorly rather than directly inferiorly, as in the cervical and thoracic regions. So the transverse processes, we said one of the most important features in the cervical region is that the vertebrae there have openings in the transverse processes. And these allow for the passage of a very important vessel, which is the vertebral artery and vertebral veins. They're very important because they supply the brain, and they supply the posterior circulation. So if you have any pathology in this region, if you have any fracture or anything going wrong within the cervical transverse processes, this may affect the vertebral artery, and the patient may end up with having symptoms and signs, neurological symptoms and signs that can be explained by a problem in the posterior circulation. So the posterior circulation is supplied by the vertebral artery via the basilar artery, and the patient may end up with having cerebellar signs and cranial nerves deficits if they have a problem within the cervical transverse processes. An important note here, and it may come up in your exams, is that the vertebral artery passes through the 6th cervical vertebra, but not the 7th. So it bypasses the transverse process here if in the 7th vertebra, and starts passing through the transverse processes when it reaches C6. The lumbar and thoracic region vertebrae don't have transverse foramen transversium or transverse processes openings in them, and they don't have vertebral arteries going through them. So they contain costal facet for articulation with the tubercle of the rib. Sorry, we didn't demonstrate this in the slides up here. So this is the body, and this is the transverse process. So you can see a flat surface here, and you can see a very small notch here. So it's kind of this end plate, this lower border of the body is not really regular. So it's posteriorly here is not exactly the same as in here. And this is also is not exactly the same as in the anterior bit. So this is because, and you can appreciate it very clearly here. This is because they have to make space for articulation with the head of the rib. So the head of the ribs or the costal cartilage will eventually sit in here. So this is called a demifacet. So a demi means half. So this is half of a facet, and this is the other half. So the head will eventually lie somewhere in the middle, and it will take space for articulation with from both of the vertebrae of the body of the vertebrae. Then you have an articulation here in the transverse process for the head of the rib. So this is the also an important difference in the thoracic region. You don't have costal surfaces here, and you don't have costal surface in the body, and you don't have a costal surface on the transverse process in the lumbar or the cervical region. So they possess costal facet for articulation with the tubercle of the rib, and T11 and T12 do not have costal facets. We'll go over this when we talk about T12 and T11. So the articular processes are a bit different in the orientation, and it may seem initially confusing. However, I think it's straightforward because you just learn one thing and then you can work out the direction of the other articular process, but just by working out from the one that you already know. So starting with the cervical region, the facets are flat. So we're talking about this joint, how one vertebra connects to the other. So this joint and this joint, which we can't really see here. So in the cervical region, the superior will always talk about the superior facet. Okay, so we'll only learn the orientation of the superior facet, and from that, from the superior articular process, and from that, we'll try and work out how would the inferior articular process would look like, or how would it be orientated. So let's look at the superior articular facet in here. So it's pointing superiorly and posteriorly. So the net direction is somewhere around there, right? It's pointing superiorly and posteriorly, and so it's kind of maybe 50 degrees, pointing mainly up, all right? So the inferior, if this was directed up and to the back, this would be directing down and to the front, right? So you just try to understand and visualize the superior articular facet, how it's looking like, and from that you can work out how this should be facing. So this is for the cervical region. Let's look at the superior articular facet in the thoracic region. And like we said, it's flat, and here as well it's flat, and you can see that this joint is almost like plates, flat plates being applied to each other. So this articular process is looking posteriorly and slightly laterally. Now, how can you visualize this as something that's looking or facing laterally? It's because here you can't actually see the inside of the joint, right? So this gray area in the middle, dark or gray area, is the surface for the superior articular process. You wouldn't be able to see that if it wasn't directed a little bit laterally. So it's as if, because we're looking at the scan, we're looking at the spine from the side, and so it's as if escaping the midline and trying to turn and face us here because we laterally, or it's trying to rotate to a lateral rotation. So you can actually see the joint. This is not happening here. You can't actually see the inside surface of the articular process. So just by understanding and visualizing this image, you can understand that that this superior articular facet is facing posteriorly and a bit laterally. Someone may say, well, this looks like it's a bit pointing superiorly. Yes, but that's a very small rotation. It's mainly back and laterally. So once we know that, it's easy to work out how is the inferior articular process is orientated, right? So this is laterally, so this should be medially. So this is posteriorly, then this is anteriorly. And lo and behold, it's facing anteriorly and medially. All right. In the lumbar region, they are curved, and this is a difference from the flat cervical region. So you can see that the articular processes, which are fairly covered here by the transverse process, so this is the articular process, you can't actually see the inside surface of it like this, so it's definitely not pointing laterally, right? So one thing is that they are facing medially. That's why it makes all the difference from this is facing laterally and this is clearly not facing laterally, because I can't see actually the joint. So this is pointing away from me. I can't really see it. So this is facing medially, and also they are concave because this is a curved facet. Remember, this is a flat facet and this is a flat facet. So one of them must be concave and one of them must be convex. So the superior articular process is concave and it's facing medially, and the inferior articular process is convex and facing laterally. The interlaminar spaces are small in this. So interlaminar just means the spaces between the laminae. So this is the lamina, this is lamina, and you have laminae here, and it just means the posterior arch. So they are small in the cervical and thoracic region, and they are short, and they are large in the lumbar region because the laminae are short, like we said earlier. This image is just here just to show you that so this is the vertebral artery passing through the transverse processes of the cervical region of the cervical vertebrae, and this image is just here to show you that the very first transverse process it passes through is the C6 vertebra and not C7 vertebra. So it doesn't pass through the artery, doesn't pass through C7 transverse process. It starts with C6 and goes all the way to C1. Now let's talk a little bit about the atypical vertebrae. So we have C1, 2, and 7 in the cervical region, T1, 10, and 12 in the thoracic region. So this is C1, and C1 is also called atlas. and C2 is called the axis. So first, lobe orientation. So this is the so it doesn't. So maybe the very first thing that you would notice is that it doesn't have a true body. So you can't actually see a bony bulk, as in sitting in the middle, and you can actually point to it and say this all looks like a ring, right? It doesn't have a true body, and that's true. So it doesn't have a body, and it doesn't have any protruding process back here. So this is a vertebra that doesn't have a body and doesn't have a spinous process. So this must be the atlas. So we said that each vertebra will have a body and an arch. So this doesn't have a body, but it has an arch. So the arch is divided into anterior and posterior arches. So when you talk about the atlas, you just say the anterior arch and the posterior arch. Here you have some features from the typical vertebra, cervical vertebra, which is the transverse foramen on each transverse processes. So it's typical in terms of these structures. Another thing that's special to the atlas is that the articulation is different because it's articulating with the occipital bone of the skull and not another vertebra. So it has an articular facet or articular surface for the occipital condyle of the occiput. On here, it's just, and this is an axial view, and this is a lateral, a coronal view, and this is an oblique view, essentially showing the same structures. So this is the posterior arch, this is the anterior arch, this is the transverse process on both sides, transverse foramen. This is the articular facet superiorly and articulating with the occiput. So next is the C2 vertebra, which is also an atypical vertebra, and it's called the axis. So so we usually talk about axial views. However, maybe the most important feature of the axis of C2 is the dens or the odontoid process, and it's so if you look here, this is a coronal view. So you can see the body. It has a body here. However, this body is producing this extension of bone superiorly, and this is called the odontoid process or the dens. In terms of the lamina, it has lamina as in normal or typical cervical vertebrae. The clinical importance of this process is that, or the dens, is that we use, so this is a CT scan, and it's a sagittal view. So we routinely look for the dens when we look at cervical spine X-ray, cervical spine CT scans. we routinely look for the dens or the dentoid process because it's the most atypical in all of the cervical vertebra, and you can easily identify it. And why would we want to identify it? That's because you can just count from it. So if you have a fracture, say here, and you don't really know what level is this, so you just look for the axis, which is C2. So this is if this was 2, this would be 3, 4, 5, and 6. So your pathology or fracture is at the level of C6, and this is a routine thing. If you crop this image and you just show me this bit, I won't be able to tell which level is this, or you may be able to, but you just won't be confident. And that's why we routinely use the dens as means of identification of the level when looking at a sagittal view scans. So we'll talk about C7 as well. It's one of the atypical vertebrae, and it's now started to look a bit more typical, right, compared to the C1 and C2. So we can clearly see a body, laminae and pedicles, and transverse processes, and you can see a spine here, or a spinous process. You can appreciate it much more here. The thing that's atypical about this is that one, it's got the longest spinous process, and also the spinous process is not bifid in the rest of the cervical vertebra. So you have large transverse process, but small transverse foramen, and it also doesn't transmit the artery, the vertebral artery, but transmits the veins, the vertebral veins. And on this side view or sagittal view, you can see the spinous process, very long spinous process compared to the breast of the cervical vertebrae. So in terms of the thoracic vertebrae, we also have atypical vertebrae. We have T1 through T12. They're all atypical. The thing that made the T1 vertebra atypical is that, so we talked about the demifacets in here. So if you look at T2, so it doesn't have a full surface for articulation with the full costal cartilage, facet for articulation of the costal cartilage. What you have is or bone. So you have is a demifacet, so it's half of a facet. However, and this is typical for the thoracic vertebrae. However, in here they have full articular surface because the C7 is not involved in formation of this articular surface. So it has a full articular surface for articulation with the ribs. In addition to that, it has an inferior demifacet. So because it contributes to the formation of this joint as well. The T11 and T12, they also have full costal facets instead of demifacets, because the head of the ribs at this level only articulate with the vertebra of the same level. So this is T12, this is T11. So they have a whole articular facet in here instead of a demifacet as in the rest of the thoracic vertebrae. And that's what made these vertebrae atypical. Am I missing? No, it's just the view. Okay. So so that was for the cervical, thoracic, and lumbar. So we'll talk a little bit about the sacrum. So the sacrum is composed of 5 fused vertebrae. You can't really tell them apart. It has a triangular or a pyramid shape. So it has a base and an apex inferiorly and a base superiorly, and it has sacroiliac joints, facets. So these are for articulation with the iliac joints. This apex is for, sorry, this base is for articulation with the L5 vertebra, and this apex is for articulation with the coccyx. And you can see it has a curved, on this view, it has a curved or concave structure, concave anteriorly structure. S1, the first vertebra, the first vertebra in the sacrum, it contributes to the formation of the promontory, which is important when measuring the size or the inlet of the pelvis. It has a sacral hiatus, and this is just a deficiency of the laminae meeting in the middle. We said the laminae meet in the middle, and they form a spinous process in here. You don't really have a fully developed spinous process here. However, you have some cover in this area. However, in the last 2 sacral vertebrae, this is deficient, and this is clinically important because you can give injection, especially anesthetics, through this inlet. And of course, you have sacral foramina for passage of the nerves in this area. So the sacral canal, this is the canal, so this is the body of the sacral vertebrae, and this is the canal through which the fecal sac passes, and it's large and capacious, and it's very important because it contains the chorda equina. So the chorda equina is when you have the cord, the actual cord ending with the cornus medullaris, there are some small nerves that continue to extend throughout the fecal sac. So this is the sac, this is the dura, and this is the spinal cord, and it ends here. So you have these nerves that are coming out, and these are important nerves supplying the parts of the lower limbs. They also supply sensation in the buttocks, the private areas, and they control the sphincters. So clinically, this is very important because you have something called chorda equina syndrome, which is a surgical emergency. Compression of these nerves may lead to pain or neurological deficits affecting the things that we just talked about. So the sphincters, the patient may come in with urinary retention or urinary incontinence. They may come in with weakness in their arms or in their legs or their feet, and it's mainly the feet, the ankles, the lower limbs, the lower in the lower extremities, or they may come in with change in sensation in their private areas or the buttocks, or they may come in with sexual dysfunction. And all these functions are very important, and they have direct effect on the quality of life and functioning of the patient. So this is a really important area to know and understand. So the subarachnoid space, it's also very common because one of the most commonly affected discs, intervertebral discs, are L5, is a disc that lies between L5 and S1. So the fifth lumbar and the S1, which is this bit here, the disc that sits on top of this vertebra is commonly affected. So it is displaced posteriorly, and it compresses these nerves, and the patient comes in with foot drop. They are unable to pick up their feet off the ground, and with, like I said, sphincteric disturbance and change in sensation, that sort of thing. So it's an emergency that needs to be treated very urgently. So the subarachnoid space continues all the way down to S2, and this is also important clinically because when you have a patient that needs a lumbar puncture as an F1, soon you may be asked to perform a lumbar puncture. So you will make use of this anatomical fact that the S2, that this sac, the subarachnoid space, which contains CSF, continues all the way down to S2 with minimal involvement of the extremely important structures, because the actual spinal cord ends at L1 or L2, but here you have plenty of space and plenty of CSF, through which you can introduce a needle and take some CSF, either for diagnostic or therapeutic purposes. It's a very common procedure that has a wide range of therapeutics and diagnostic, and it's used by the surgeons and medics alike. So the last bony bit we'll talk about is the coccyx. So these are 4 vertebrae fused together, similar to the sacrum. It's small and triangular, and it also has an apex, and a base. The base articulating with the sacrum, and the apex extending all the way down to is at C4. Sorry, C4 as in coccyx. So that's it for the bony bit. We'll talk about some of the aspects of blood supply in the spinal cord. The blood supply of the spinal cord is provided. The arterial supply is provided by 3 major vessels: the anterior, single anterior artery, and 2 posterior arteries. The anterior spinal artery is formed by the junction of the 2 or 4 branches of the vertebral arteries. So each vertebral artery contributes by a in this diagram you have the spinal cord extending all the way up here from the cervical region. This is the cervical enlargement, this is the lumbar enlargement, and this is here the cornus medullaris. This is the water arch, and here the important bit is the vertebral artery. So you have the right vertebral artery and you have here the left vertebral artery. So each vertebral, and the vertebral artery eventually join together and form the basilar artery. So each vertebral artery produces a branch, and the branches from the two sides meet in the middle, and they form the anterior spinal artery, which runs longitudinally throughout the or in front of the spinal cord. The anterior spinal artery is important because it's the major, maybe the most important of the vessels here, because it supplies the anterior 2/3 of the spinal cord. So although it's one and these are two, it supplies 2/3 of the spinal cord. The important thing about the anterior spinal artery, and this is also kind of a rule to the rest of the spinal cord blood supply, it's very regional, and it receives segmental supply or contributions from variety of levels, from variety of arteries at different levels. So these are called radicular arteries. So the radicular arteries are basically branches that come off different vessels throughout the course of the anterior spinal artery, and they join the anterior artery and contribute to the blood supply here. So you have two at this level, so radicular artery at C3, and you have radicular artery at C3. So this radicular artery is coming off the left vertebral artery. This one is coming off the cervical trunk. This one is a radicular artery at C8, and coming off the, sorry, this is coming off the deep cervical artery, and this is at the cervical trunk. And here you also have a T5 level radicular artery coming from intercostal arteries. So these are the intercostal arteries, and this one supplies the anterior spinal artery at this level at T5. Here you have a major artery called the artery of Adamkiewicz, or arteria radicularis anterior magna, and it's important because it supplies a major part of the sorry, this is the contributors again, so C3 and C6 and C8, cervical trunk, and then again at T4 and T5. So the artery of Adamkiewicz is important because it supplies it's the main blood supply. It is the main arterial supply to the spinal cord from T8 and all the way down to the corners. So the anterior spinal artery really depends or needs the artery of Adamkiewicz starting at T8. Most of the time it's located on the left side, and its location also varies between different individuals. However, in 85% of people, it's between T9 and L2. So it's important to distinguish the location from the blood supply because it sends branches up and down. So although it's located, sorry, I'm going back and forth. Although it's located at, say this is T8 and this is 9, so it's located from T9. It supplies this segment. It also supplies this segment of the spinal cord because it sends branches up as well as down. Okay, so it starts. So in terms of supply of spinal cord segments, starts as T8. However, the level where it's actually located starts at T9 in most people. In 75% of people, it ends at T12. So here it's going all the way down to L2, but in some subjects it ends at T12. In the remaining 15%, it's relatively short. It's from T5 to T8, and it lies also higher. So instead of starting at T9, it's starting all the way up at T5, but also ends compared to this prematurely at T8. But this is a small percentage, and in generally, when you're thinking about the artery of Adamkiewicz, just remember that it supplies the whole lower thoracic and all the way down to the cornus. And we said that it gives off cephalic and caudal branches. All right, the posterior spinal arteries, they are less well defined than the anterior spinal arteries, and they have also radicular branches, so they receive segmental blood supply, 10 to 23 branches. So there is some anastomosis between the anterior and posterior spinal arteries, and these branches or these vessels are called vasa corona. The mid-thoracic region is an area that's commonly injured because the blood supply is not well established there. It's a watershed area. So in case of hypotension and a vascular insult that affects the whole of the spinal cord, for example, hypertension or shock, the area that's most commonly affected, at least in theory, is the mid-thoracic region because it's a watershed zone, so it doesn't receive very well blood supply. There is in some subjects you will find that the anterior spinal artery, when it's about to end at the cornus, so we're looking at the end or the cornus in here, so the end of the spinal cord, the anterior spinal artery, instead of ending, it kind of curves around the cornus and then joins the posterior spinal artery. All right, so this is the posterior spinal artery in here, and this is the anterior spinal artery. So you can see it goes to here, and here it's making the curve and showing up here posteriorly. So it's kind of connecting with the posterior spinal artery. And this is a normal variant, and this is called arcade of Lazarus. So the last bit we'll talk about is the venous drainage, and I just think about the internal epidural plexus because I feel like the major venous drainages through the internal, of course, is segmental. When you talk about the spinal cord, blood supply is always segmental. But in general, it's mainly the internal epidural plexus. So the internal epidural plexus will be 2 anterior and 2 posterior veins. So here you have the anterior and posterior internal vertebral venous plexus. They're kind of just outside the dura, really, and they are connected. They accompany the spinal cord, and all the way up they connect to the vertebral veins and the occipital sinus inside the cranium. The external venous plexus lies, so this is outside the canal, and it lies surrounds the body of the vertebra, and they drain into the esophagus system and ascending lumbar and lateral sacral veins. The bits that are running horizontally in this picture are called the passive vertebral veins, and they drain into the external or internal venous plexuses. I think that's everything. In terms of the references that I prepared these slides from are mainly Snell's. I like Snell, to be honest. I used to read it when I was in medical school. So to be honest, I think most of my slides are were copied and pasted from Snell's Clinical Anatomy. The second book on here is called Greenberg, and this is a neurosurgical handbook. Also quite nice, and most people in neurosurgery just learn this for their exams. This is not Pro Radipedia, it's Radipedia. Also very nice website made by radiologists, and it's for everyone really. It has all the most of the abnormalities. If you wanted to look at it, when you Google it, the first thing you find is Radipedia article. The last bit I think it was obvious. These nice 3D structures are from Anatomy Standards. They have very nice websites, and from Radipedia and courtesy of Zenso, and you can use it with no problem. Anatomy Standards is same. However, I think they're just doing osteology, but I couldn't find any soft tissue anatomy in the website. I think they're quite in the beginning, but it's a very promising and very useful site if you wanted to do some osteology learning. Thank you, everyone. And if you have any questions, happy to answer any.
Lovely. Thank you so much, Sam, for that very in-depth talk on spinal anatomy and also the clinical application. If anyone has any questions, as we said before, just raise your hand and we'll just address it. In the meantime, Hussam, do you have the QR code for the feedback on your slides by any chance? Ah, brilliant. There we go. So yeah, as always, guys, if you can just scan that code and give feedback as evidence for your attendance. And again, as I said before, if anyone has any questions, please just raise your hand and yeah, get a scene too. Right, it doesn't look like anyone has any questions. I think it just goes to show that your talk was quite comprehensive for some. So if no one has any questions, you can just fill in the feedback form, and yeah, I guess we'll see you next week, guys. Take care.
Thank you.